talking about bone matrix and alterations in bone matrix. So osteopenia is the kind of the precursor to osteoporosis. It's where your bone matrix, the density is actually declining, so your bone mineral density is actually declining. And they do that by several ways, by looking at lumbar vertebrae. Calcaneus is another bone that they can actually use to look at it. So osteopenia is kind of a warning that your bones are beginning to lose density. So there's a lot of evidence to suggest that the density that you created through your formative years and teenage years until you reach adult stature is real critical. And then afterwards, the maintenance of that density is very critical. So we talked about foods that have high calcium, making sure you have high calcium in your diet, and tying exercise into your lifestyle so that you put force on bone and keep the bone remodeling with osteoblasts and osteoclasts. So if you continue to lose bone density, then you convert from osteopenia to osteoporosis. And it's a loss of not only the mineral matrix because of a lack of calcium, but also the organic matrix. So it's essentially a total loss of bone matrix itself. So if you look at risk factors that influence it, European and Asian ancestry seems to be the people that are at highest risk. Right? So then within that group, family history is also important. So if you have grandparents or other members in your family that have had osteoporosis, then that's kind of a warning to you early in life that you might want to think about it. So it's based upon body build. So the more petite you are, the more important it is that you maintain adequate calcium in your diet and do an exercise regime that makes you remodel bone. Inactive lifestyle. So as I said, tying exercise together with it. And then there's a lot of new retirement centers that actually have some amazing swimming pools and exercise rooms for elderly people to get them active and involved in exercise. Cigarette smoking impacts it and promotes it over the long haul. And then in women, early menopause. So women who tend to go through menopause in their late 40s, early 50s compared to 60s are without estrogen for a longer period of time. And we know that estrogen is very important to the process. And so some women can be put on estrogen replacement therapy and so prolong the impact of menopause. But again, that's individual based upon whether you have any risk factors for ovarian cancer, breast cancer, and some other cancers as to whether you could actually use replacement therapy for that. Excessive use of alcohol, we know, promotes it. Obviously, a low diet of calcium and advanced age. And one of the things that has happened in our population, which is good from my standpoint, because I'm getting older, is that people are living longer. And so we have a lot of people now living into their 80s and 90s. And so we see more osteoporosis than we used to see simply because of a population with more advanced age. So if you look at other groups, African and Hispanic women are, African American and Hispanic women are at a lower risk than European Asian, but still at a significant risk. And then anytime you're put on drugs, you have to think about how drugs interact with metabolic responses in the body. So there are some data that suggest that medications for lupus, some asthma medications, some thyroid deficiencies, and some seizure medications impact the movement of calcium in the body as well. Okay, so what actually happens and why we can use like the greater trochanter on the femur or lumbar vertebrae is what we would want to see is lots of trabeculae building the lattice work in spongy bone on the inside of your bones, and in these open areas where we actually have red bone marrow. So this is a normal bone density slide. This is an abnormal bone density slide with osteoporosis. So what you'll see is the bone eventually and cross-bridging is gone, and the open spaces in the bone are getting bigger. And so that makes the bone weaker. And so some elderly women with osteoporosis can actually cough and break ribs because the ribs are becoming weaker and weaker.
Will the body fill up those extra open spaces with more red bone marrow, or just leave them?
Maybe, depending on your age. So this is actually an autopsy picture. These are lumbar vertebrae, the bodies of lumbar vertebrae. And so this is a person who had osteoporosis. And so this would be what the vertebrae body should look like in terms of its length. These two are pretty good. So we begin to notice that this looks really dense, but we get these big open spaces in here, and that's actually osteoporosis. This one's actually collapsed. And so what's happened is the vertebrae is actually collapsed on itself because of osteoporosis. And that's why some elderly people are really hunched over. You actually lose height as you age naturally, and with osteoporosis you can lose height at a more rapid rate because you get these compressions of the vertebrae. So my stepfather is in his late 80s, and he has osteoporosis. And it was actually compression fractures like this his lumbar vertebrae that made it so he could no longer be at home, because he went from being able to walk around to pretty much wheelchair bound because of pain in his back if he tried to walk. And so he had to be put in the center because of it. And so what we're seeing is just these big osteoporotic areas within the lumbar vertebrae. So it's a good thing to think about calcium as you age. Okay, so osteomalacia is a slightly different disease, and it's not a loss of bone salt. So it's not created by deficiencies in calcium, problems with calcium metabolism in your body. Excuse me, it is. I need another. Excuse me, I need to drink a coffee. It's a loss of bone salts, but not pollen. So it's essentially a demineralization of bone due to poor diet. So you keep your organic matrix, which is collagen and the chondroitin sulfide, but you lack the hydroxyapatite formation. So actually the bones get more and more soft in terms of pliable. And then that's on that in what we call rickets in children, is where they have a loss of bone matrix in terms of bone salt. And I showed you a picture of rickets earlier. So a couple of other diseases. Paget's disease is a disease where the remodeling process and the coordination and interaction between osteoblast and osteoclast goes array. And so what we end up with is remodeling bones in an ununiform way, where bones get thin in some areas but thicker in other areas. So instead of having a uniform diaphysis on bone, you actually have variations in because of the remodeling process. So osteomyelitis, so anytime we end the word in itis, it's usually indicates an infection or inflammation because of some event. So osteomyelitis is actually an infection of the bone. And the most common way it happens is you have a fracture or something, or you've had a total knee replacement, total hip replacement. And what happens is the most common bacteria on your surface of your skin is Staphylococcus aureus. And it's draped on the surface of your skin, and it's in your mouth, but it's not good inside your body. So people with prostheses and hip and knee replacements, as I told you yesterday in lab, for the rest of their life, anytime they have dental work or anything, they have to take antibiotics first. So these bacteria that commonly form a plaque in your mouth, the Staphylococcus aureus, actually don't get into your blood where it goes to the bone and targets the bone and creates a bone infection. So then if we have an open if we have an open fracture, we're always concerned about subsequent infections with Staphylococcus aureus with an open fracture. And then osteogenic sarcoma. So osteogenic tells us it originated in bone. Sarcoma tells us it's a cancer of connective tissue. So the two words we used to describe the origins in terms of tissues was carcinoma, which we used in the last unit with skin cancer, which is a cancer of epithelial tissue, and then sarcoma, which tells us it's a cancer of connective tissue. So the site of origin of the cancers themselves. And then osteogenic sarcoma is most common in teenagers because it actually impacts the growth plate. And so it's a bone cancer that affects osteoblasts and the metaphysis of long bones, particularly in the growth plate area where the growth plate is undergoing rapid mitosis due to the influence of human growth hormone. I actually had a cousin who had osteogenic sarcoma as a young teenager, 12 or 13, and at the time the way they took care of it is they just amputated that part of her leg so that they just removed the cancer by amputation. So I now there's some better treatments. So this is an example of bone cancer. This isn't osteogenic sarcoma. It's actually a metastatic bone cancer where the cancer's origin was somewhere else and it just started growing. So this is actually a tumor. And so the way to think about a tumor is that something's gone wrong with mitosis, so the cells are rapidly undergoing mitosis. Normally they would, once they've undergone mitosis, they would maturate and differentiate into a particular cell that belongs to the tissue. But in this instance, what happens is they just end up as a large wad of undifferentiated cells. And then what the cancer does is continue to displace normally functioning tissue. As the normally functioning tissue is impacted, and your body's ability to maintain homeostasis is impacted. So what you can see here is the cancer has grown into the medullary cavity, and so it's taken over this area of the diaphysis of the bones. This is obviously somebody who died from the cancer. This is an autopsy. But it also lets us review some things we talked about bones. So this is the diaphysis of the bone with medullary cavity and yellow bone marrow. At the ends of the bone, we actually have the epiphysis, and we can see the hyaline cartilage, the little white stuff that was covering the articular surface at this distal end, and we can see the hyaline cartilage covering the articular surface at the proximal end. So what bone is this?
The femur.
It's the femur, yeah, it's a femur. And so it had an greater trochanter, lesser trochanter. And then the other thing we can see is this line right here. And so if this line was really white like that going across, it would actually be a growth plate. But this is actually an epiphyseal line. And that tells you where the growth plate was originally, but it's been ossified. So.
Yeah.
Did this cancer originate in the periosteum?
I don't know.
Okay.
I actually don't remember the history of where the cancer originated. My guess is it originated in Oregon, somewhere else. But you can actually see the periosteum going around the cancer of the bone. Okay, so the other big one that we hear a lot about and a lot of people are impacted by, and as we were looking at the skeletons in the lab, we could see the telltale signs left on bone material of arthritis. So the prefix, part of the word arthro is a reference to joint. And so arthritis is a literal translation to inflammation of a joint. And so what we have is we have a couple of types of arthritis. So osteoarthritis, or DJD, degenerative joint disease, is very common in elderly people, and it's one of the reasons why we have total hips and total knees done in our geriatric years, because the joint itself ages to the point where it's no longer functional. So I had an uncle that had to have a total knee done, and he had already ground a 16th inch of bone off the top of his tibia when he had his total knee done, because the cartilage was gone, and every time he was walking, then it was rubbing on the bone, and so that's why he had to have a total knee done. My mother's actually wore on one side, not the other, so as the bone wore, it created force in the joint because it tipped the bones, which created a lot of pain. She had to have a total knee done. So that's one of the reasons why we see that done, is because just the degenerative disease. So it occurs with age, it occurs with certain occupations that have a lot of use of a particular joint. And then we have inflammatory joint disease. And rheumatoid arthritis is one of the more common ones. It can be identified fairly early with blood work to confirm what a practitioner might recognize as some early signs of rheumatoid arthritis. And I've got a picture of it here in a second. And one of the areas of interest is that it looks like maybe that it's a viral infection. And we have viruses that incorporate genetic material into our genome, retroviruses. And they actually change our genetic makeup. And what they think it is where the virus alters the cell identifiers on the cell, and then you attack your own tissue. So it's an autoimmune attack against cartilage, the collagen in the bone of the joints itself. And then another type of inflammatory arthritis is gouge. So gouge arthritis is caused by a metabolic problem where we have trouble managing amino acids that are found in proteins. And because we have a problem with an enzyme that manages a particular amino acid, it builds up in our body. It gets converted to uric acid, which is the type of nitrogen that birds release instead of urea, which is what we release in our urine. And then it causes swelling in the joints, where the joints get really inflamed, and you get these big nodules on the joints that make them painful. And oftentimes in the feet, and on the feet, but you can get them in the hands as well. So here's just examples of things that you can see clinically. So a little more on rheumatoid arthritis. So it typically affects your hands and feet, which affects the dexterity eventually in people, and create pain and joint deformities over time. So if you look at risk factors, women are more likely to develop rheumatoid arthritis than men. So when you're thinking about managing healthcare and making healthcare costly, controlling costs, then it makes a lot of sense to have a screening technique where women, particularly women with a family history of rheumatoid, are screened early, can be put on drugs early, so that the disease doesn't become as debilitating later on. So usually it begins at 40 to 60, so it would make sense to screen people in their early 40s if there's a risk factor for it. So family history, if members of your family have rheumatoid arthritis, you have an increased risk of it. It doesn't mean you're going to get it, it just says that you have a more increased risk. And then smoking cigarettes increases your risk of rheumatoid arthritis. So certainly if you're high risk, it would be worth treating for a number of reasons. And so this is an elderly woman with rheumatoid arthritis. So you can see the deformities in her fingers. And then these are the x-rays of those hands. You can see how these joints are totally degenerating here. And so what bone is this?
Metacarpal.
Pardon?
Metacarpal and second right.
Second metacarpal, very good. And so you can see it's degenerating at the end. And you can see the deformity in the joints in the thumb as well. And that makes it really hard for them just to do things like tie their shoes, button their clothes over time. So the other one is pretty fascinating because it's related to rheumatoid arthritis in the sense that it was actually being misdiagnosed. for a while as rheumatoid arthritis. And so actually what was going on, I'm going to start at the bottom and go back up. So what was going on is that there were a group of children that lived in Lyme, Connecticut. And they were diagnosed with rheumatoid arthritis. And then a bunch of parents who were dealing with this, who began to do some research, saw that the age group that we just talked about, that its most common onset is in the 40s to 60s. And so they were going, why in the world does my kid have a disease that they shouldn't have until they're in their 40s? And so they began to question whether it was really rheumatoid arthritis. And that's what pushed some researchers to actually begin to look at what was going on. As it turned out, it was actually a disease caused by a bacteria that was being transferred to individuals by the bite of ticks. And so what ticks do is they have a long proboscis that they have to extend down in through your keratinized stratified squamous, and they have to get it into the papillary region of the dermis because that's where your blood supply is. So to do that, what they do is they create saliva that lubricates their proboscis as they push it in, and then the saliva has an anesthetic agent that deadens your sensations. So the tick can actually push its proboscis down through your skin and you don't feel it. But what was going on is the bacteria in the saliva of the tick. So as the tick is salivating to push its proboscis through, it transferred the bacteria to the individuals it was biting. So it became known as Lyme's disease because of its original source, where it was actually figured out what was going on. And then the early manifestations are fever, headaches, fatigue, depression, and then characteristic skin rashes. And then if it's untreated, then it begins to look more and more like osteoporosis. Rheumatoid arthritis over time. So it's kind of interesting disease. And then we looked at these yesterday, total knee replacement and total hip replacement. So the good news is the tick isn't real common in the West, but it's starting to, one of those interesting things about the world around us. So the tick was much more common in the East. So whenever I went to the East to go birding, it's a specific tick. Yeah, it's a deer tick, yeah. And so when I went to the East and I'd go out in the woods birding, I'd always make sure I look for ticks and put stuff on them. Ticks don't lie because they don't come back to Lyme disease. But it is beginning to occur in the West. So that's one of the things that you, as a young group of people going into healthcare, are probably going to see. So independent of what you think about climate change, we know it's occurring, whether it's natural, whether it's man-influenced. That really doesn't matter to me. And what really matters is it's going to profoundly impact Medicare. Profoundly impact medical care. And we're already seeing it, where mosquitoes that carry certain diseases that we strongly associated with the tropics, because the mosquitoes can't tolerate the cold, are actually moving from the equator toward the poles. So we're seeing those diseases further and further away from the equator. And so there's already been malaria in the southwestern part of the United States. And it was at one time totally a tropical disease. So as that happens, plus we introduced a couple of diseases into the United States from the tropics by shipping tires and stuff. And so as it happens, we're going to see these changes in disease, in the way diseases are behaving in the world. So I'll be moving to the last. Keep going north. Pardon? All right, so probably not my way. So what we started with yesterday in lab was thinking about the way we can classify joints. And so there's kind of two ways we can classify joints. One is saying what kind of action occurs at the joint. So if the joint has no movement in it, we call it a synarthrosis. And sutures are an excellent example between the bones of the skull. The epiphyseal plate, which technically is cartilage connecting the epiphysis to the diaphysis of the child, is actually a joint at that point. And so that's called a synchondrosis. And then a synostosis is the conversion of the epiphyseal plate to the epiphyseal line in a mature bone that I just showed you in that x-ray. So an amphiarthrosis is a slightly movable joint. And so the one we looked at in lab was a syndesmosis. And that word syndesmosis is used to describe the distal interaction both in the leg and the lower arm. So the distal end of the tibia and the fibula, where the fibula sits in a little groove in the tibia called the fibular groove. And then the distal end of the radius and ulna, where the ulna sits in a little depression in the head of the radius, in the radius, not the head, the distal end of the radius, called the ulnar notch. And then what happens is those bones have to be held together tightly by ligaments. And yet there has to be a little bit of movement in those as well. And then a symphysis is classically where the pubic bones are held together in your pubic symphysis. And then also the intervertebral discs that we talked about yesterday keep the bodies of the vertebrae in approximate location. So those all have very slight movement in them. And then diarthritic joints are our most common type of joint in the body, and they're freely movable joints. And then as we look at how joints are structured, so the structural classification of joints and the functional classification of joints, we can kind of overlap them. So the connection with diarthritic joints is all diarthritic joints are structurally synovial joints. And in a synovial joint, we have the bone, the end of the bone of each bone is lined with hyaline cartilage. And then we produce synovial fluid, which is a viscous lubricating fluid that allows cartilage to glide over one another without friction and wear. And so it protects the joint. And so just examples that we've looked at in lab. So any of the sutures in the skull are an example of what kind of synarthrosis. So it's this particular suture. This might be the terminal suture. So then a synchondrosis, an example would be, again, the growth plates, the epiphyseal plates. And actually, the femur is got more of a complex one. It has actually got a growth plate in the head, and it's got a growth plate in the greater trochanter. So it's actually got two growth plates, which means they have two centers of ossification in the epiphysis. And then the pubic symphysis was what kind of joint? Amphiarthrosis, a slightly movable joint. And then a syndesmosis, again, it is the distal end of the lower leg where the fibula sits in this fibular notch of the tibia. And you don't want that joint to come apart because it spreads apart and your foot would go up between the two bones. That sometimes happens when people fall off roofs or ladders, try to land on their feet. It actually does break the fibula and drive their foot up between the two bones. And it takes quite a bit of surgery to repair that. So there's an interesting one, and if you look at textbooks across the board, you'll see them listed two different ways. So the unique junction between your teeth, and what are these places where the tooth fit into the animal maxilla called? Alveolar processes. So where the tooth fits into the alveolar process, we have a bunch of little ligaments called periodontal ligaments that go from the tooth to the periosteum of the bone, and that's what keeps the teeth in place. So if you've ever had a tooth pulled, when they grab it and pull, you can actually hear those periodontal ligaments popping as they pull the tooth out. And then So some people think it's immovable. Other people argue that it's slightly movable. If you actually put your teeth together and try to move your jaw back and forth, you can actually feel your teeth flex, which is what you do when you're chewing. So it's called a gomphosis. Like the unique joint with teeth is a gomphosis. And diarthritic joints are most of your body joints. So if we look at structural classification, then what we're not worried about is the action of the joint, but we're worried about what the material is that holds the bones together. So we can have fibrous joints, and fibrous joints are going to be held together by dense connective tissue. And there will be no joint space. In other words, the bone is held tightly together to another bone without a joint cavity being present. And then a cartilaginous joint also has no joint cavity. So there's no space in the joint. But instead of the bones being held together by dense irregular or dense regular connective tissue, they're being held together by a type of cartilage. So the two types we would commonly find would either be hyaline cartilage or fibrocartilage in the cartilaginous joints. And then in a synovial joint, which are all diarthritic joints, we actually have a physical space in the joint, and we put synovial fluid in that space to lubricate the articular ends of the bones in the joint so that they don't wear. And we have cartilage lining the ends of the bones in a synovial joint. So fibrous joints that we've just talked about, which would span from synarthritic joints like sutures, are fibrous joints, to syndesmoses, which were amphiarthritic, which was an amphiarthritic joint, is a fibrous joint because what holds the joint together are ligaments. And then in the tooth itself, where you have an alveolar process, and you have these periodontal ligaments that cross between the periosteum and the bone and hold it. So in a gomphosis, those are all fibrous joints. Yes.
What would the hyoid bone classify at? Would it be like a tooth?
Well, the hyoid bone is one of the interesting bones in your body because it technically doesn't articulate with any other bone. So the hyoid bone is a unique bone in that it interacts with soft tissue and cartilage to support your larynx and to provide attachment to the roof of the root of your tongue. So it technically doesn't articulate with any other bone in your body.
But a tooth doesn't connect technically it doesn't connect any other tooth.
No, it will, but it's a bone-like material that's connected to the maxilla, the mandible.
Okay.
So if we look at cartilaginous joints, the one we looked at was the pubic symphysis, which would be hyaline cartilage. And that's an amphiarthritic joint that provides some flexion, particularly in childbirth. And then synchondrosis, which is hyaline cartilage. So epiphyseal plate would be a good example where you want no movement at all. And then the first rib and the manubrium where you want no movement at all. So this would be an example of a cartilaginous joint that's an amphiarthrosis. And this would be an example of a cartilaginous joint that's a synarthrosis. So we have both examples in cartilaginous joints as well. So the example we were talking about is the connection of root 1 with the manubrium. And that's critically important for respiration. So when we go from normal respiration to deep breathing, then we have to pull our rib cage upward to increase our respiratory ventilation. And so what happens is we have muscles that actually connect to rib 1, and they're going to pull rib 1 upward. And so you don't want any flex in that joint because you want to transfer all the force of the muscle to elevating the rib cage so that you can actually convert to labored breathing. And the pubic symphysis that we've looked at in the lab before. So when we get to synovial joints, the one thing that really define synovial joint as a unique type of joint is that we have this space that exists between the bones and kind of to the outside of the joint itself. And so that's a joint capsule. And in the ends of the bones are going to be covered with hyaline cartilage. And what covers the outside of the joint capsule itself, which we call a synovial cavity, is actually a synovial membrane. So this is the synovial membrane. It comes off the edge of the hyaline cartilage, crosses in a three-dimensional way back over to the next bone. And so you have this joint space that's surrounded on the articulation surfaces of the bone by hyaline cartilage, and away from those articular surfaces by this synovial membrane. And then it produces synovial fluid, which helps lubricate the movement of the cartilage overall. And then to the outside of the synovial membrane, then we have more dense connective tissue that maintains the joint. And so that's called the articular capsule that actually goes through it. So before my mother had her total knee, we tried to prolong the surgery. And so I'd take her to an orthopedic surgeon, and he'd take a long needle, and he would put this viscous liquid in her knee that would help kind of act like synovial fluid to decrease the friction so her knee didn't hurt as well. And when I was asking him, he said, yeah, it's really easy to know because when the needle passes through the articular capsule, there's a pop, and then you know that you've gone into the joint space. And then he would inject that stuff into her knee. And so we use, you can do 3 of them, and then if at the end of 3, then they want to do the surgery. So we were able to prolong the surgery for a couple of years, but she would get about 6 months of relief with each injection. So, yeah.
What produces the synovial fluid?
The synovial membrane.
Okay.
So this membrane actually produces the fluid.
What is it, and how do they make it? How's it made?
Well, it's epithelial cells that are secretory cells. I one time remembered, I don't remember the exact chemical makeup of the synovial fluid. I can look it up quickly.
Is there any big difference between that and, say, a cortisone shot?
But cortisone shots decrease inflammation. So they decrease pain by taking the inflammation out of the tissues. So that's a little different mechanism. But certainly people get cortisone shots for joint pain. Oftentimes in vertebrae, they do it for a long period of time before they will do surgery because of the risk of surgery. So they'll give that. You can also do just spine, you can do nerve blocks so that you don't feel anything. So there's several things you can do. All right, so what we did in lab, so I can do a quick review, is that we actually looked at the knee. So tying the last picture together with this one, then you can see how this cartilage is on here. So the synovial membrane would connect to the edge of this cartilage all the way around. Then it would cross and connect to the edge of this cartilage all the way around. And then, so the ligaments we talked about yesterday, the cruciate ligaments, the cartilage we talked about, the meniscus, they're all inside of that joint cavity, and then they're surrounded by synovial fluid. So they're within the cavity itself. The ones that aren't within the cavity are the collateral ligaments that we talked about, that are on the side of the knee that we did. And so remember, our cruciate ligaments arise from the intercondycular eminence of the tibia, and then they go to the intercondycular fossa of the femur, and they actually cross, which is why they're called cruciate ligaments. So you can see the pattern at which they cross. So the anterior one starts anterior and travels posterior. The posterior one starts posterior and travels anterior. So you can see this is the insertion of that posterior cruciate ligament on the anterior plane, and then this one's crossing backward. And so the cruciate ligaments are designed to prevent the knee from being able to be hyperextended, and then also to try to eliminate rotational force in the knee itself. And then what we talked about in lab yesterday was the fact that because this is a real round surface, and the tibia is actually, the condyles are very, very flat, then we have these cartilages that create the socket in which the bone is going to set. And so they're the meniscus. So we have a medial meniscus and a lateral meniscus in which these condyles actually interact. And so this is kind of a side view of what we were just talking about. So you can see how there would be a membrane that comes off this, crosses all the way down to this one, and then conversely up here. Then we end up with this joint space there that's going to have synovial fluid in it. This is the edge cut of the meniscus. So you can see how the meniscus is larger as it goes outward to create the socket in which this bone is actually going to set. And so then the other thing that occurs at joints, because oftentimes you actually have tendons of muscles crossing each other or tendons and ligaments crossing each other, is that when you actually move the joint, you would have friction against these tendons or ligaments. So where the friction occurs, we have little pockets of synovial fluid that are lined outside by a synovial membrane again that make them. And so these little packets of synovial fluid are called bursa. And then if they become inflamed in a joint, you have bursitis. And so our knee, because of the way the knee works, has several bursa to limit that friction that would occur when the knee is being flexed backwards like that. And so the only thing on top of your kneecap is actually skin. And so to protect your kneecap, you have a little bursa that's just under the skin. And so it's a little sac of synovial fluid. So it's called prepatellar bursa. And in a clinical environment, if somebody has fallen and hit their knee hard on something, that bursa will actually swell with fluid. And they can get so bad that when they come in, it looks like they have half orange sitting on top of their knee. You can push on it, and it gives a lot. So what they do sometimes to eliminate that pain is to take a needle, inject it in there, and then pull the extra fluid out of it so that you can decrease it. And so that protects our kneecap from trauma. And even because the patellar ligament that connects to the patella to the tibial tuberosity here, as the knee is flexed and the knee rotates this way, then it creates friction against this piece of bone. And so we have an infrapatellar bursa sitting just behind the patellar ligament that protects that friction. And then at the top, because of the way the tendon of quadriceps fits, again, as you flex your knee backward, it's pushed back in against the bone. And so we have a suprapatellar bursa behind the tendon of quadriceps. Those bursa all are designed to decrease friction of soft tissue. All right. So now what we want to do is kind of change our attention to the kinds of joints that we have in our body. And the way to think about this is that joints are designed to provide a range of motion. So certain joints in our body are designed to only provide one range of motion. Other joints in our body are designed to provide two ranges of motion. And then a few joints in our body are designed to provide three ranges of motion. So when you're looking at the pictures, if you just see one arrow, then this joint is designed to only do one range of motion. So it's called a uniaxial joint. If you see two arrows, then that one's designed to provide two ranges of motion on two different planes. So it's a biaxial joint. And then as you get to some of the more complicated joints, such as a ball and socket joint, then what you'll actually see is three arrows indicating that there's three ranges of motion, and that's a triaxial joint. So basically, as we look at it, as the joint becomes a very round ball as a head that fits into a socket, then we can have a greater range of motion, which is why our hips and shoulders have such a great range of motion. Right? So a lot of joints are just designed to be planar joints. And they are very flat pieces of bone and flat articular surfaces are designed to glide on one another. And so excellent examples of planar joints would be what allows us to flex our foot. And so if you look at the calcaneus back here and the talus up here, the talus interacts with the navicular. And then the navicular interacts with bones that are associated with the first phalanx, second phalanx, and kind of third and fourth phalanx overlapping. So they're called cuneiforms. So first cuneiform, second cuneiform, third cuneiform. So the articulation between the second and third cuneiform and the navicular is a gliding motion that allows you to flex your foot a bit. So your knee and elbow are classic hinge joints. And a hinge joint is designed to allow you to only do flexion and extension. And if you try and do anything else but flexion and extension, then you damage the joint. And so they're really designed to do that. So the best designed one is actually the elbow, where you have this very deep recess in which the humerus is going to set. So it's called the trochlear notch. And then the trochlea was the smooth surface on the medial side of the humerus. So here's our medial epicondyle. And then when we did the notch, we learned that this projection was the coronoid process. This big projection back here was the olecranon process. And they actually are bone to define the range of motion within the knee, within the elbow. With the knee, then the tibia condyles are very flat compared to this, even though the femur condyles are very rounded like this. And then we have to use the soft tissue, the meniscus, to help create the socket in which it's going to fit, which is why knees are the most commonly damaged joint. So a pivot joint is a joint that allows for rotation to occur. So the best example would be the head of the radius articulating with the radial notch on the ulna. And then remember, the radial notch was our landmark for left and right on the ulna. So in anatomical position, the radius is on the lateral side of the arm. So the ulnar notch would have to point to the lateral side of the arm on this. And so what this joint allows you to do is to either pronate your arm or supinate your arm and bring it back across. So classic pivot joint. The other pivot joint would be the adens or odontoid process of C1, of C2, and the interaction with C2 that allows you to medially rotate, lateral rotation, medial rotation of the head. So a condyloid joint is going to be a joint where there's a curved surface that fits into a curved depression. And so a good example would be the interaction with the first two carpal bones, the scaphoid in line with the thumb, and then the lunate. And in both of these bones, the scaphoid and the lunate fit into a depression at the distal end of the radius. And then that allows us to do flexion and extension of our wrist. And then in anatomical position, abduction and adduction of the wrist. So two different planes that it can actually move on. So a saddle joint is similar to a condyloid joint, but the depression is deeper and the rounded process is more pronounced. So it's the same type of joint, but there's a more rounded process and a deeper depression in which it fits. So an excellent example would be the joint down here with your thumb, right? And so the fifth carpal, the trapezium, and the first metacarpal of the thumb. And so again, it allows for two actions. So at this joint right here, you can do this, and you can do this. So two different actions that you can actually do with that joint. So it's called a saddle joint. So then your hip is the best designed ball and socket joint. Again, because you've got a very deep socket, the acetabulum, on the ossipods that the head of the femur fits into. When you look at the shoulder, which is another ball and socket joint, when you look at the end of the scapula, the glenoid fossa is really flat, even though the head of the humerus is fairly round. And so we actually have to use soft tissue again and cartilage to create a socket in which the head of the humerus is going to fit. And so there's actually a cartilage called the labrum that helps create the socket. And so that's something that can be torn by repetitive hard motions with the arm itself. And so that's why people who do lots of repetitive hard motions like throwing a baseball and other activity can get shoulder injuries. And so the unique thing about those ball and socket joints with our hip and our shoulder is not only can we do flexion and extension on this angle, abduction and adduction on this angle, but circumduction with the joint itself. So we have three distinct planes of movement within the ball and socket joint. Okay, so while you're looking at these, just think about the joint, the examples here, think about the motion that occurs in each joint. And that kind of leads us into what we talked about in lab, which were specific types of motion that we can create at a joint. So in the first example, what we're looking at is what's called the atlanto-occipital joint. So occipital because of the occipital condyles are involved, and atlanto because C1 and the correct name of C1, the other name for C1 was the atlas, makes up the joint. All right, and so what you have is the superior articular surface of C1, which is a concave depression, and then the occipital condyle, which is a very rounded process that interact, and is designed from anatomical position to where you're looking forward. So the word flexion is a reference to a decrease in an angle of the joint. The word extension is an increase in an angle of the joint. If you can go beyond anatomical position, then the movement beyond anatomical position is hyperextension. So with this joint, you can do this, which is flexion. You can do this, which is, and you can do this, which is hyperextension. Okay? And then with our hands as well. So in anatomical position, our hands are in line with our arm. So this is flexion. This is, and this would be hyperextension. So with the arm, in anatomical position, it's in line with the body. So if we bring the arm forward, it's flexion. If we come back to anatomical position, that movement is, and if we go beyond it, it is hyperextension. So the elbow in anatomical position is a 180-degree angle. This makes it a 90-degree angle, so that would be flexion. This would be, and the elbow is not designed to hyperextend. Then we can do the leg and the lower leg and the hip. So at the hip, this movement is flexion. This would be at the knee. This is flexion. This is and
hyperextension.
It's not designed. You can hyperextend. It's not bad. It's very bad. It's good. It leads to an ACL tear. All right. So the next action is the reference is the midline of something. So it could be the midline of your body. It could be the midline of your hand or your foot. So in anatomical position, your arms are like this. So if you bring your arm out, it is abduction, abduction. You bring your arm back down, it is abduction. So with your hands, then if you go out, it is abduction. Go in, it is adduction with your wrist. With your leg in anatomical position, so if you go out, it is abduction, abduction, With your hands, it's the center point of your hand. So in anatomical position, when your fingers are together, they are adducted. When you spread your fingers apart, they are abducted. So, and then the unique action with the ball and socket joint, which creates our third plane of action, is circumduction. And so your shoulder can do circumduction, your hip can do circumduction. So what we can do is rotation. And so all joints are named with the parts of the joint involved. So allanto, atlas again. The second cervical vertebrae is called the axis. So the allanto-axis joint is telling you the interaction between the first and second. So you have the dens that creates the pivot point, and C1 rotates around it. And that's why the inferior articulating surfaces of C1 are very flat, and the superior articular surfaces of C2 are very flat. And so you get this gliding rotation. And so from anatomical position, if you look this way, it's lateral rotation. If you look back, it's medial rotation. So with your arm, if you rotate your arm this way, it is medial rotation. You come back, it is lateral rotation. So this picture is really confusing. So it's easier just to actually use your instead of bending your knee, to look at it this way. If you rotate in like this, it's medial rotation, lateral rotation. So with your mandible, if you open your mouth, it is
Depression.
depression. And then if you close your mouth, it's
Elevation.
elevation. So depression and elevation. If you stick your mandible out, it is protraction. And if you stick it back in, it is retraction. So then we can use that with soft tissue. If you stick your tongue out at someone, it is protraction. And if you put your tongue back in your mouth, it is retraction. Yes?
So elevation and depression, would that apply like when you shrug your shoulders?
Yes.
Would that be the same?
So, yeah, if you shrug your shoulders and bring it up, it's scapular elevation. If you put your back in place, it's scapular depression. Yes.
Does your clavicle move?
Because your clavicle doesn't move a lot. It flexes because it's attached to the acromion process. So it flexes and elevates upward. So with your feet, if you roll your foot so that you're standing on the outside edge of your foot and the plantar surface of your foot is pointed inward, and that is inversion. If you roll your foot so you're standing on the medial edge of your foot and the plantar surface is pointed outward, then it is eversion. So inversion and eversion and inversion. And then technically, because the ankle is a 90-degree angle in anatomical position, if you stand on your heels and draw your toes off of the ground, then that's true flexion. And then if you go up on your tiptoes, that is hyperextension. But what they commonly use with the foot is dorsiflexion as you pull your toes off the floor, and then plantar flexion as you stand on your tiptoes. But you could use hyperextension as well. So the one we did already is palms forward. Your hand is said to be supinated. Palms backward, pronated. And we're done.